Welcome back to another episode of Healthy Chicago podcast. My name is Irina Tabidze. By training, I'm a medical epidemiologist, but currently I serve as a director within Division of Public Health Services, Syndemic Infectious Disease Bureau at Chicago Department of Public Health. Joining me today, Taylor and Jahanavi. Do you guys want to introduce yourselves?
Yeah, thanks for having me today. My name's Taylor Hawley, and I'm an epidemiologist within the Syndemic Infectious Disease Bureau here at Chicago Department of Public Health.
And hi, I'm Jahanavi Ramakrishna. I'm currently a clinical infectious disease fellow at Rush University, Systems for Health, and super excited for our conversation today.
Thank you both for joining us. Today's podcast will focus mostly about the Mpox, what we're seeing with the Mpox. But before we talk about the Mpox, Taylor, I would like you to talk a little bit more about the syndemic approach and provide the definition for our listeners.
Yeah, so syndemics is when two or more diseases or health conditions co-occur together or interact with each other, or they have the same societal drivers. For example, we see Mpox and HIV co-occurring a lot, and those with advanced HIV are at risk of more severe Mpox disease.
Thank you, Taylor. That's very important to know the term. Let's talk about the Mpox. So what are the most recent data trends? Can you share with us where we are as of right now here in Chicago?
Yes, absolutely. So starting in June of this year through today, October 29th, we have seen a total of 146 cases of Mpox within Chicago. Just to note, last year in the same time period, we only had 33 cases, so that's a 342% increase.
Wow.
Additionally, we do see most of these cases are among gay, bisexual, and same-gender loving men. We do see majority of them among non-Latinx white individuals. The median age is 34 years old, but that ranges from 20 to 68 in our cases. Most of our cases are on the north side of the city, but we see a lot of cases on the west and the south side, so it is affecting everyone in our community.
I'm just curious, Taylor, how does what we're seeing right now in Chicago compare to what we're seing nationally?
Yeah, absolutely. So nationally, especially in urban areas, we are seeing an uptick of cases of Mpox. I don't think it's really at the magnitude of what we're seeing in Chicago, but there still is an increase.
Jahanavi, hearing what we know about where we are with the data currently, can you talk more about clinical presentation of Mpox?
Definitely. So Mpox can vary in clinical presentation. It can be anything from mild self-limiting disease to very severe disease with long-lasting complications. Typically, what we see is a prodromal phase followed by a rash. And the prodromal phase is when patients will experience flu-like symptoms, so fevers, chills, muscle aches, swollen lymph nodes, which is really common in Mpox. And then the rash, which is probably the most well-known feature of Mpox, will present with skin lesions that are usually painful, and they spread from the center outwards to the arms or legs in disseminated disease.
So we interview a lot of our cases, and one of the questions that we get asked a lot is, how long do these lesions last? Like, how long are people having to potentially isolate?
Yeah, no, that's a great question, Taylor, and that's definitely something that we as providers also get a lot of questions in talking to patients. So the typical Mpox lesions go through 4 phases. First, you'll have papules, which are more flat, and then vesicles, which are fluid-filled, which progress to pustules. And in the final stage, they'll crust over, and the scabs will fall off, revealing new healthy skin that's coming through. And that's when you really know that you're healing and when patients are no longer considered infectious. This can vary, and it can take anywhere from 2 to 4 weeks. It's really important for providers to know that you can see lesions co-occurring at multiple phases, and lesions have been described everywhere on every body surface, including like mucosal, all mucosal areas.
Are there any atypical symptoms that our community or providers should be aware of?
Yeah, absolutely. So in the global outbreak that happened in 2022 to 2023, there were several novel clinical presentations of Mpox that were most likely driven by transmission via intimate and sexual contact. The presentations that were described weren't really captured in the original case definitions put forward by the WHO and other larger public health agencies. So we saw more lesions involving the anogenital, oropharyngeal, and vaginal mucosal surfaces, with a huge proportion of patients presenting with just anogenital lesions. Other presentations to note are proctitis, pharyngitis, urethritis, and also ocular disease. And we see severe Mpox, especially in immunocompromised patients. So they can also present with necrotizing skin lesions.
Very interesting. Taylor, earlier you mentioned that when we interview the patients, can you talk more about it? Are we doing case investigation, contact tracing, and also do we have any patients who present with the similar clinical presentations as Jahanavi just shared with us?
Yeah, absolutely. So when we get cases in from electronic lab reporting or from provider reports, we aim to interview all cases. So we reach out to this patient within 24 hours, and we ask a variety of questions asking about the symptoms. So we do see a lot of our cases reporting having genital lesions. Not every case does report having genital lesions, though. Some can report it on their hands or their arms or in their mouth, like in the oral. Additionally, we ask about sexual contact within the 3 weeks prior. So majority of our cases do report having sexual contact during that time period, but there are a handful of cases that do not report that as well. So we do know that some people have shared bedding, potentially utensils as well. I do want to note some of the other things that we ask is about other conditions. So if they are immunocompromised. So we have seen that 22% of all of our cases are co-infected with HIV currently. And then a third are co-infected with either HIV, syphilis, gonorrhea, or chlamydia.
Taylor, I think it's so interesting and relevant that you bring up syphilis because from the clinician standpoint, syphilis is definitely one of the things on our differential when thinking about Mpox. So both primary and secondary syphilis can present with skin lesions that look like Mpox, but they're typically painless. And then also in secondary syphilis, you can see disseminated rash, which is something we're starting to see a little bit more with Mpox. Some other things that we keep on our differential are herpes simplex viruses, so HSV, but in those cases, the lesions usually ulcerate instead of scabbing over. And then other infections like chickenpox and molluscum contagiosum as well.
Thank you, Jahanavi. Knowing what we heard just now, I think it will be important to hear what are the latest recommendations from the testing perspective.
Yeah, so I cannot emphasize enough that with the outbreak we're seeing currently in Chicago, Mpox should be something that both clinicians and the community are thinking about. Anyone with symptoms of Mpox or anyone who has a known or possible exposure to Mpox really should be tested. Folks can get tested at any walk-in STI clinic, ER, urgent care facility, also with their PCP. So there are plenty of places that are doing testing right now. So the lab test of choice is a polymerase chain reaction, which is a type of molecular test. And right now, data has shown that the highest yield is from skin lesions, regardless of what stage they're in. The commercially available test can be listed in various ways at different institutions. So it can be listed either as Mpox, monkeypox, or orthopox virus PCR. So I highly recommend that providers, if you're struggling to order it, just ask your institution's lab how you should be placing that order. And then I know that the CDPH Mpox Han website has recently been updated with guidance on specimen collection. So I highly recommend that providers check that out.
Yeah, absolutely.
Thank you, Jahanavi. Can you please also talk about the treatment recommendations?
Yeah, so unfortunately, there are still no U.S. FDA-approved treatments for Mpox. Tecovirimat, or TPOXX, is an agent that the U.S. FDA approved for smallpox back in 2018. And then in the 2022-2023 outbreak, the CDC approved it for emergency use in Mpox for patients who are eligible. And there are quite a few eligibility criteria, and they have that listed on their website. The decision to use TPOXX really should be made on a case-by-case basis with the treating provider. I do, however, want to note that a lot of studies that have looked at TPOXX in Mpox have found that even though TPOXX is safe to use, it really does not make a difference in terms of changing the healing time for skin lesions.
I'm really glad that you brought up TPOXX because I know that's something that gets mentioned to our case investigators as well. So within these 146 cases, we have seen 6 hospitalizations among them. So some of these hospitalizations were just like an overnight observation. Some were longer, maybe a week or so. And then some of these cases that were hospitalized were also immunocompromised. So, that was something that was discussed with their physician who was treating them, like if they needed TPOXX or not. But I do want to emphasize that what they all had in common is that they were all unvaccinated.
Definitely want to double tap on that, Taylor. That's something really important in thinking about Mpox, is making sure we're getting vaccines out there.
Yeah.
Why don't we dedicate some time now to talking about the vaccinations and what are the recommendations for vaccinations?
Absolutely. So the Jynneos vaccine is a live but non-replicating, which is an important point, especially for immunocompromised patients. Non-replicating smallpox and Mpox vaccine that requires a 2-dose series. It became available in the U.S. in 2024, and the efficacy rate of the Jynneos vaccine in patients who get both doses ranges from 66 to 86%, but majority of studies report over 80%, which is pretty good. Understandably, in patients who only get 1 dose, the efficacy rate is lower, but in this case, some protection is better than no protection at all. And I do want to say, breakthrough infections are possible, rare, but possible. Even in those cases, in patients who are fully vaccinated, we are really seeing milder disease with fewer skin lesions and other complications.
So you said it's 2 doses. When can someone, how long is the series? When can someone get the second dose after their first dose?
So the second dose is usually 4 weeks after the first dose. And we've also been getting a lot of questions about boosters and also in patients who have had Mpox, if they need to get vaccinated after, their acute infection resolves. And I will say, we're learning a lot about that right now. Historically, because the Mpox outbreaks have been so short, we've never really considered boosters. And, in terms of recommendations, boosters are currently not recommended for the general public. And the same goes for vaccinating people who have already had Mpox and have natural immunity.
Yeah, we definitely get that question quite a bit, too, from our patients after we, interview them. They're like, hey, can I get vaccinated? And I think that's really important to, note so that you don't have to get it. You shouldn't because...
Well, so in patients who've already had the infection, like I said, they have natural immunity. And then right now, boosters are just not something that we recommend for people who have already been vaccinated with both doses.
I'm going to follow up on Taylor's question. Since we're interviewing the individuals, sometimes we interview the contacts as well, exposed contacts. And I think it will be important if you can share the guidance on the post-exposure prophylaxis.
Yeah, absolutely, Dr. T. So the Jynneos vaccine is also recommended for post-exposure prophylaxis. And really, this comes down to a discussion between the patients and their providers in terms of the degree of risk. So out in the community, high-risk exposures include, folks who have been exposed to Mpox due to sexual contact, especially involving mucosal barriers, folks who share the same household who have, come into contact with skin lesions of patients infected with Mpox. And then also in the same household when you're sharing, I think, Taylor, you mentioned this earlier, but sharing common household items like sheets or utensils, those are considered higher risk exposures. And in that case, we do recommend in folks who have not been vaccinated previously and are 18 years or older to get the Jynneos vaccine ideally within 4 days from the time of exposure, but that can be extended up to 14 days. The earlier, the better, though.
Do we need to consider anything else? For example, if exposed contact has symptoms versus being asymptomatic, is there anything that will be helpful for listeners to know?
Yeah, that's a really good point, Dr. T. So these recommendations for vaccination as post-exposure prophylaxis are really in asymptomatic individuals. If a contact has any symptoms that are concerning for Mpox, they really should talk to their provider, get tested, and hold off on vaccination until otherwise told to do so by their provider.
So if someone has a fever, they should not?
Yeah, ideally they should not be getting the vaccine. They should not be getting Jynneos as post-exposure prophylaxis.
Okay.
Do we have any other tools in the toolbox, prevention toolbox?
Definitely. So, patients who are infected with Mpox definitely should be isolating in shared households. The lesions should be covered. We also recommend hand washing and, again, not sharing certain common household items like sheets, utensils, and making sure that surfaces are being appropriately cleaned and wiped down.
Thank you, Jahanavi. Any questions that we wanted to discuss?
Yeah, I actually have a question. As a provider who's out in the field, I wanted to ask you, Dr. T and Taylor, from the CDPH standpoint, what has been, the response to this outbreak that we're seeing, and what's the community engagement been like?
Do you want to start?
I'm going to let you start, actually.
So Chicago Department of Public Health is working closely with the healthcare providers as well as our community partners, and we will be sharing more information soon regarding specific response. And I would defer to Taylor to provide some additional information.
Yeah, so I know we've been doing a lot of vaccine pop-up events, and those are still happening. We have them scheduled throughout November and December. I do just want to really note that this has really been coming and working because we are seeing cases decrease now, whereas we were up to at the max 2.4 average cases per day. We are now at 1.1 case per day, which is still higher than what we would normally see, what we've seen normally at this time, which were normally less than 1 case per day, but it has been going down. So our efforts that we are working with the community, working with providers, hosting these vaccine events to get those who are not vaccinated or who have only had their first dose to come back in and get their second dose.
That's
done.
Really reassuring to hear.
It's been a lot of work, but working with a lot of people at CDPH, not just within the Syndemic Bureau. We've worked with immunizations, communicable disease, PIO, even chronic disease has helped with some of their staff helping us. So it's been a lot of work, a lot of collaboration. That's been amazing.
And we will be sharing more information soon, which provides additional details about coordinated response from Chicago Department of Public Health. As we're wrapping up, I wanted to ask both of you, is there any takeaway messages that you wanted to share?
Yeah, I think from my standpoint, I really want to re-emphasize that with what we're seeing now in Chicago, Mpox should be something that providers are thinking about on their differential when seeing patients. And also, providers and patients alike should be thinking about whether or not immunization, like vaccination for Mpox, is right based on, a person's risk factors or the potential for them to be exposed to Mpox.
Yeah, I just want to piggyback off that with the vaccines. I think, really getting it out there that we need to push vaccine, that it's safe, it does help keep based on what you had mentioned, it helps with protection and keeping the disease more mild if you are to have a breakthrough case. I do want to right now plug our sexual health clinics for CDPH. They do provide vaccines at all of our clinics on the north side. So we have one in Lakeview, one in Austin, and one in Roseland. You can go and get tested for HIV, syphilis, gonorrhea, chlamydia, as well as other prevention tools like PrEP for HIV or DoxyPEP for STIs.
And all of this is free, right? If I'm not mistaken?
Yes, it's all free. And we just add that we have clinics across all of the different parts of the city. We have clinics on the north side, as Taylor mentioned, but we have clinics also on the south side and west side of the city as well. Thank you, listeners. Thank you, Jahanavi. Thank you, Taylor. And thank you, our listeners. And that's our episode. And please share and subscribe to our podcast. Thank you.